I'm going to talk today about disorders of consciousness, neurobehavioral assessment, and outcomes. And I do receive some grant funding and have some royalties for the book that I edited. Today, we're going to focus on describing the features of vegetative minimally conscious state, as well as emergence from a minimally conscious state. And we'll review some of the neurobehavioral measures that can be used to assess individuals in a disorder of consciousness, and discuss also predictors of outcome. And so I'm going to start today by defining what disorders of consciousness, what I mean when I say disorders of consciousness, and then we'll review some things related to assessment, outcomes, as well as treatment options. So disorders of consciousness is defined as severely altered arousal and or awareness of the self in the environment. Typically, they're thought of in terms of three different stages: coma, vegetative state, which is also termed unresponsive wakefulness syndrome, and minimally conscious state. I have a couple of pictures here that I want to direct your attention to. If you're interested in this topic, there's a really nice documentary called Coma, which was initially an HBO documentary that describes and goes through chronicling 4 individuals in a disorder of consciousness and their recovery. And you get to see kind of their experience as well as the experience of their families during that, during the documentary. The other resource here on this page is this book by Joseph Finn called Rights Come to Mind. And I am including that here because when we think about disorders of consciousness, it often brings up ethical issues around withdrawal of life or continuing life-sustaining treatments when somebody may be expected to have a very severely impacted outcome. And again, if you're interested in this topic, that book is wonderful. So the terminology related to disorders of consciousness has changed a lot over the years. Initially, vegetative state was first defined in 1994 with the Multi-Society Task Force on Persistent Vegetative State. At that point, the different criteria for vegetative state were described. The term minimally conscious state is a newer term, was developed in 2002 and defined by the Absent Neurobehavioral Work Group. And I mentioned vegetative state is sometimes called unresponsive wakefulness syndrome. That is a term that began to be used in 2011, is used very frequently in Europe, but is gaining some traction here in the US. So when we think about the neuroanatomic structures that underlie consciousness, we think about areas such as the basal forebrain, the hypothalamus, the thalamus, the ascending reticular activating system. But we know that consciousness is quite complex and many different areas of the brain are involved with consciousness. I'm not going to go through this diagram, but I'm showing it just to highlight the complexity of consciousness. And when thinking about the neuropathology of disorders of consciousness, we think about 3 main types of pathology that can result in a disorder of consciousness. One would be diffuse cortical injury. Another would be diffuse subcortical injury with or without brainstem injury. And a third would be bilateral thalamic injury with relative sparing of other parts of the brain. So just to describe the criteria for these different states of consciousness a bit more fully so you kind of have a better understanding of these terms. Coma is that period from injury or illness where there is no eye opening, no evidence of sleep-wake cycles, and generally no responses. Individuals typically move from a coma to a vegetative or unresponsive wakefulness, often within 4 weeks of coma at maximum. Sometimes it's a bit longer. And what you see at that point is that there's periods of sleep-wake cycles, not necessarily normal sleep-wake cycles, but periods of arousal where eyes are open, but all of the responses are reflexive. The next state of recovery is minimally conscious state. During this state, eyes are open at times, and there is periods of inconsistent but purposeful voluntary behavior. The most kind of low-level behavior we see might be visual fixation or visual tracking. But you also, in a minimally conscious state, may see higher-level behaviors such as command following or intermittently answering yes, no questions, or maybe even saying a few words. Emergence from a minimally conscious state is defined objectively as an individual who answers yes, no questions consistently or uses objects functionally consistently. The minimally conscious state can be broken down further into minimally conscious plus and minimally conscious minus. So minimally conscious plus are higher level behavioral responses or language-based responses like command following, intelligible verbalizations, or occasional yes, no responses, where minimally conscious minus is lower level behaviors like visual pursuit, visual fixation, location of noxious stimuli, or contingent affective responding, meaning smiling or laughing if someone says something funny, or looking sad, or maybe being tearful if somebody is saying something sad. So this is just another kind of depiction of the states of consciousness and the progression through those states of consciousness. Brain death is not a state of disorder of consciousness, and neither is classic locked-in syndrome, where somebody may not be able to move at all, including moving eye movements, but is fully aware cognitively of what is going on. I'm going to talk in the next slide about these kind of more functional locked-in. So this is just another depiction of multidimensional assessment of consciousness. And you can see here kind of everything that's above this line here are things that we can measure using behavioral assessments. And what we see down here and what's getting more and more attention are evidence of covert cognitive processing or cognitive motor dissociation, and where you need instruments like fMRI or EEG in order to detect these types of processing. So I'm going to move in now that we kind of all are on the same page and have an overview of what disorders of consciousness includes. We'll talk a bit about behavioral assessment for diagnosing states of disorders of consciousness. And I'm going to highlight, I know the slide is busy, I'm going to just show you a couple guidelines that came out of a paper that was published in 2018. There was two papers, a systematic review and a practice guidelines. And the practice guideline included 18 guidelines for assessment, outcome, and treatment in individuals with disorders of consciousness. As you know, I'm a pediatric provider, but the vast majority of literature on disorders of consciousness focuses on adults. So I'm going to talk a bit about the adult literature and then highlight what we know about children. So what these guidelines say in terms of overall care and diagnosis for adults, I want to just highlight this recommendation number 1, which is clinicians should refer patients with a disorder of consciousness who have achieved medical stability to settings staffed by multidisciplinary rehab teams who specialize in assessment and treatment of individuals with DOC. That's really important because many individuals who have an injury or an illness that results in a disorder of consciousness end up in a long-term care facility where they are not getting the treatment that they need or the careful assessment that they need in order to detect signs of consciousness. Now, the pediatric disorder of consciousness recommendations from that practice guidelines, so there was 18 recommendations, 3 only related to children. So I'm going to highlight a bit the first one, this recommendation 16, which kind of going back here, all of these recommendations 2A through F kind of focus on similar things to what's here combined in recommendation 16, which is that we should treat confounding conditions, increase arousal, maximize arousal, and then use standardized behavioral assessments targeted for children that are conducted serially over time. So I'm going to talk a bit about some of the tools that are used for these serial assessments. The most commonly considered tool is the JFK Coma Recovery Scale Revised, which is the gold standard assessment for behavioral assessments for individuals who have a disorder of consciousness, based on a systematic review that was done in 2010, looking at reliability and validity of a range of measures. I developed a modified version of the CRSR called the Coma Recovery Scale for Pediatrics, which I'll talk a little bit about. Another measure that I like to use is the Rappaport Coma Near Coma Scale. You'll hear a bit about that today. There are many other measures that can be used, but I'll be today focusing on just the 2 measures, well, the 3 if you consider the CRSP, that are highlighted or that are bolded here. So starting with the Coma Recovery Scale Revised, just to give you a little bit of overview, that scale has an auditory function scale, a visual function scale, a motor function scale, oral motor verbal function scale, a communication scale, and an arousal scale. Both the motor scale and the communication scale have items that denote emergence from a minimally conscious state. So I mentioned that before in terms of functional object use, which is basically a simple measure where you hand somebody an object like a spoon and you say, show me how you use the spoon, or a brush, so show me how you use the brush. And you're looking for consistent differential movement or attempt to use that object functionally. Where functional communication is a simple measure looking at the ability to answer yes, no questions using here and now questions like, am I pointing to my nose right now? Am I pointing to my ear right now? And I wanted to clarify that because I'm going to talk a little bit about that as it relates to the CRSP and assessment of children. I worked with the developers of the CRSR to create a measure that would be effective and useful for children as young as 6 months of age. And so we modified the items of the CRSR using things that made it more child-friendly, like adding toys instead of objects like spoons and brushes. And then we also changed some of the administration and scoring criteria. So functional object use, we also used spontaneous play, not just using objects functionally to command, as well as functional communication. We added the use of a picture book to make it a little bit more engaging for a child. And we made a few other modifications. I'm going to just highlight a couple of things. So when it came to functional object use, what we found was that children as young as 12 months of age were able to demonstrate differential use of play with toys. But about half of those kids, and we only had 4 in this group, but of these 4 kids, half of them required the modification. So they did not play when we handed them a ball and said, so show me how you throw the ball. they would show you the ball often, but they wouldn't throw the ball. But if you provided a number of toys and watched what they did, we saw spontaneous play that was different with different toys, throwing a ball versus shaking a rattle. But we didn't see that the children did it on command until they were at least 3 years of age. So this tells us that the CRSP can be useful in the youngest children to detect disorders of consciousness. Keeping in mind that this is a preliminary assessment of this measure because these were typically developing children, and they were also a bit higher functioning in that the average education of the parents in this convenience sample was having a master's degree. For functional communication, we found something similar, but also at a later age. So we found by the time children were 3 years of age, they were able to consistently demonstrate yes, no. But one of these 4 children did not demonstrate that without the use of the picture book, which was a bit more engaging. So in this case, am I pointing to a mouse right now? Or am I pointing to a cow right now? And it wasn't until age 4 that children showed consistent functional communication without the modifications provided with the CRSP. This is a very recent data that my colleague, Dr. Stacy Suskauer, just presented last week at a meeting looking at some of our clinical patients using the CRSP. And what we found was that we were able to differentiate different states of consciousness as well as see progression through the states. What we did find was that many children began demonstrating spontaneous play, and then clinically the clinicians stopped using the instrument because it wasn't needed anymore. So we saw often functional object use or functional play reported in therapy sessions. And so therefore the measure was not necessarily needed as we progressed, but we did see clear progression. And one of the things that you'll note here is that all of the children that emerged from a minimally conscious state emerged due to functional object use, not functional communication. So we saw the motor the motor behavioral index of emergence before the language and the language item that showed emergence. And then this just shows kind of the children's kind of emergence over time, and that the CRSP was able to be used to diagnose various states of consciousness, all states of consciousness, VS, MCS minus, MCS plus, and emergence were seen in this clinical sample using the CRSP. I want to kind of move to another study that we did where we looked at behavioral features of the various states of consciousness based on the Aspen Neurobehavioral Work Group guidelines. And those features are listed here. And we used a clinical sample where we reviewed neuropsychology notes to diagnose various states of consciousness. And this, at the time, we were using primarily informal assessment as well as the Rappaport-Cohen coma scale. So these children were not receiving the CRSR or the CRSP. And what we found is that in a group of 54 patients with a range of acquired brain injuries, about 31 had traumatic brain injury, that we were able to identify children that had functioning consistent with, instead of CS, which is conscious state, I now am calling this emergence from a minimally conscious state, because even in children, there is a movement towards thinking about when you emerge from a minimally conscious state, you really don't emerge to a conscious state. You're still in a disorder of consciousness, typically a confusional state, or post-traumatic amnesia or delirium. This has been much better described in adults, but is also described in children. but I'm not going to talk much about that today. I'm going to focus on VS, MCS, and then emergence from a minimally conscious state. So these children were considered emerged from a minimally conscious state. 15 children were thought to be in a vegetative state, and 15 children were thought to be in a minimally conscious state. But what we found also in that study was that this was at admission. At discharge from inpatient rehab, 9 children who were initially in a vegetative state were emerged to a minimally conscious state, and 15 in a minimally conscious state emerged from that minimally conscious state. But no child who was at a vegetative state emerged all the way through to from a minimally conscious state. That is a little bit different than our clinical data, where we looked more recently and found definitely a number of kids who started in a vegetative state who then emerged to a minimally conscious state. All of these samples are very small. This is a pretty rare condition, and it's challenging to evaluate these children without doing multi-center trials. But what we found in this group of 54 children, when we looked at the 15 that were thought to be in a minimally conscious state at admission, we found even though command following is a sign of a minimally conscious state, none of the children displayed that. None of the children displayed intelligible verbalizations. These very young children, again, this is under the age of 5 and under in this population. But what we saw was primarily things like visual fixation and pursuit or contingent affect. So like our typically developing children, we didn't see language evidence of a minimally conscious state until later. And this is features of emergence from a minimally conscious state, similar to what we found in the typically developing kids. I keep thinking I have arrows here. The most common emergence was associated with this functional object use, where functional communication was seen less frequently. So in typically developing children and in children who have had brain injuries, what we see is that visual and motor skills may be most applicable when assessing pediatric disorders of consciousness, especially in these very young children. Language-based assessment is least applicable. So we also find that doc evaluations really do need to be modified for the youngest children. And what we didn't look at in any of these studies, and what needs more evaluation, is really understanding pre-injury delays, developmental delays or deficits, or how to address those with visual and or motor impairment post-injury. We certainly need caution when assessing those children. And we also have some inklings that accurate classification may be important for prognostic has important prognostic implications, which I'll talk a bit about now as we move forward in the next couple of minutes. I just wanted to highlight a couple more things related to assessment. Sometimes we use individualized assessment, where we target a few behaviors of interest, and this could be arousal, it could be command following, it could be vision and hearing. When somebody is showing inconsistent responses, which is the hallmark of a minimally conscious state. So I'm going to just show you a quick video here of a young man who was in a disorder of consciousness, sustained an anoxic injury after an acute case of transverse myelitis, which caused a spinal cord injury as well as an associated anoxic brain injury. So he only had movement in his face. So let me go ahead and just show you a few things. I want you to do some things for me. Open your mouth. Real big, open it big. Open your mouth. Let me see you open. And I'm going to show you one other part here.
Tongue.
Oops, let me just...
Stick out your tongue. Let me see you do it. Stick out your tongue. Good. I'm trying.
Okay, so typically when I give this talk in person, I usually ask people how many people thought he opened his mouth, how many people thought he stuck out his tongue on command. And usually people are very uncertain about whether he opened his mouth or not, very skeptical. Some think he might have followed the command to stick out his tongue. This is a great example of when we would use an individualized protocol where we would develop a very specific command that all of the therapists would do, the physical, occupational, speech therapist, for just maybe 5 minutes of each of their sessions, which across the day would give us 6 different observations of each command plus a period of observation where there's no command. And in this case, what we saw is that this patient was able to open his mouth, but we saw it by observation almost as much as we saw it by command. In contrast, he was much more likely to stick out his tongue on command, and we saw that much less frequently by observation. That then gives us something to work towards in addition to thinking about it diagnostically. Another thing that we think about when we're doing assessments is assessing an individual's preference. And this is a preference assessment that was developed for individuals in disorders of consciousness at Kennedy Krieger by Adriana Amari. It was based on a preference assessment developed for individuals with severe intellectual disability, where you first do an interview with family and therapist, identify what potential stimuli may be, either alerting or calming or neutral or negative. We try to find things that are positive. But in fact, what we see is that things sometimes that we think are positive turn out to be not as useful as we would like. So for example, a fan in this case, this graph is not related to the patient I just showed, but it's just an example. And another thing we think about when we think about assessment that is used more for research purposes are things like EEG and fMRI. I mentioned this briefly at the start of my talk, but here you see an individual with who has cognitive motor dissociation. This person has activation when they hear language, music, and when asked to imagine moving. This person here is thought to have covert cognitive cortical processing, has some activation with language and music, but not to motor imagery. And this person here, in a coma, we're not seeing any activation. Of note, both this person and this person are on behavioral assessment, showing this person's only showing reflexive responses, and this person is only showing minimally conscious minus responses, so only occasional visual fixation or visual tracking. So there's definitely evidence in some cases of individuals who have more cognitive processing than we're able to assess through our behavioral tools. So moving into outcomes. And again, this is from the adult guidelines. And I'm just going to show you that there's numerous adult guidelines and then summarize them here. And I think some of the important guidelines are clinicians must avoid the statement of universally poor prognosis the first 28 days after injury. So the term persistent vegetative state should be replaced with prolonged disorder of consciousness of 28 days or greater. And this had strong evidence supporting this. The other piece of the other guideline I want to highlight is that showing behavioral evidence of a minimally conscious state by 5 months after injury or illness is associated with more favorable outcomes. And then I'll talk a little bit about that in children. And then also, given the frequency of recovery of consciousness 3 months after non-traumatic vegetative state or 12 months after traumatic vegetative state, the term permanent vegetative state should be replaced with chronic vegetative state. And this table here is a meta-analysis that was done as part of this systematic review, which shows the percent of patients who recover consciousness. And you see the much higher rate of recovery of consciousness by 12 months, 78% in individuals who had a post-traumatic vegetative state versus a much smaller amount who've had non-traumatic injury. In the pediatric guideline was much more vague. Counsel families that the natural history and prognosis is not well defined, and therefore there's no evaluations to improve prognostic accuracy. That's not what we found in some of our research and what has been found in a little bit of other research, but that systematic review had a pretty high bar for what it included, only included studies of individuals that were at least 28 days in a disorder of consciousness, and the pediatric literature doesn't necessarily only include individuals that are out that far. So in adults, MCS plus versus MCS minus or vegetative state, early in rehab is associated with less disability at 6 weeks. This has also been found in a combined sample of children and young adults in a facility in the Netherlands that sees children up through age 25. And what they found is in that group, those admitted in MCS were more likely to emerge than those admitted in a vegetative state. The table here shows a small sample from our group. And what you see here is that 80% of those who were in MCS plus at admission emerged, where none of those in MCS plus did not emerge. So there's really some compelling evidence that identifying these states of consciousness, serially assessing them, and looking for emergence to minimally conscious state can be helpful for prognostic purposes. This is a study that we did looking at children admitted, this is TBI only, 37 children admitted to our inpatient rehab. And of those 37 who admitted in a disorder of consciousness, 27 of those children emerged from a minimally conscious state by 1 year. And then importantly, 2 additional patients emerged by the most recent follow-up. So we looked at 1 year of those that came back to our clinic, and then the most recent follow-up that we have from our clinic data. Overall, 78% emerged from a minimally conscious state at some point. And of those, 95% of those in MCS and 69% of those in VS at admission emerged. This is that same group, just looking at their functional outcome. And you can see those that were VS at admission are the darker colors. So the darker colors, the solid dark is VS at admission, and how they looked at 1 year, and the hashed lines are most recent follow-up. And the light gray are those that were MCS at admission, the solid being 1 year and the hash being the most recent follow-up. So you see that the GOSE categories, the higher the category, the worse the functioning. Those that were in a vegetative state at admission had worse functioning at 1 year and most recent outcome than those that were in a minimally conscious state. But also what we found here is 18%, a small minority of these patients changed and improved in category from 1 year to their most recent follow-up, showing that we see important recovery in at least some children, even after that first year after injury. This is a recent study that just was published this month from our group, showing children with anoxic brain injury. Not all of these children came to inpatient rehab in a disorder of consciousness. This is the functional independence measure for children, so lower scores is worse. But we see that those down here that were likely in a disorder of consciousness at admission, if we didn't see recovery by discharge, they likely stayed quite impaired by their 12-month follow-up. And that's important and similar to the adult literature, which suggests that we see more recovery in individuals after traumatic brain injury than after anoxic brain injury. So to summarize outcomes after pediatric DOC, most children with TBI in DOC at admission to rehab demonstrate functional impairments by discharge and at 1 year, but we see important improvements in a subset of children. And state of DOC at admission is associated with outcome. So being VS versus MCS is associated with outcome, but prognosis is less favorable after anoxic brain injury as it is in adults. So I'm going to briefly mention some treatment for adults and or for treatment for disorders of consciousness. So again, there's a number of treatment recommendations for adults. But for children, the recommendation is counsel families that there's no established therapies for prolonged disorders of consciousness. I wanted to kind of also just highlight that a study came out in 2020 focusing on the minimum competency recommendations for programs that provide rehab services for persons with DOC. So this also just provides a bit more guidelines, but again, it's focused on adults. Some of the things we think about in inpatient rehab is really working on prerequisites for functional activities, as well as preparations for home management. One of the things that we think about with prerequisites for functional activities is if we can have somebody who has trouble moving have 2 different movements that they can show reliably, then we might be able to develop a yes/no response and have more of a window into their underlying thinking skills if they are actually processing more. So I showed you this patient before, and we agreed as a team that we thought his sticking out his tongue on command was promising. We also found in a preference assessment that one of the things he really enjoyed was heavy metal music. So this is an example of the speech therapist using a tongue switch to try to motivate this patient to stick out his tongue more fully so that he could activate a switch playing his preferred music, and then hopefully reinforce that movement so that we can move to some way of communicating more consistently with him.
Your tongue out, Matthew. Good, all the way out. Push. Harder. Good job.
Okay, so that's an example of one of the things that we would do in inpatient rehab. I'm just going to briefly mention some considerations for medication selection. So when children come to our inpatient rehabilitation, often they've been trialed on medications in the ICU. Sometimes they're also taking sedating medications for a range of issues. One medicine that has been found to be efficacious in adults is amantadine. There was a randomized clinical trial looking at the use of amantadine in adults who required inpatient rehabilitation that found that rate of recovery improved in those receiving the amantadine. So it is something that we do trial in children. We also think about comorbidities and what medications might be most useful. So for example, we think about levodopa cinnamon, which is alerting, but also can help with dystonia. And so that's also a medication that we may try. If we think a patient may have mood concerns, we may, for example, start with an SSRI. And we also think about comorbid conditions that may be exacerbated by neurostimulant medications. And in fact, that patient that I showed you had a previous to his injury, had a period where he had a tic disorder. And when we initially tried methylphenidate, he developed tics, which made using his ability to use his face and to communicate very challenging. So that was a medication we had to stop. So putting it all together, we think about our assessment informs our intervention. And we think about optimizing sleep, getting therapies, behavioral and environmental changes, preferences, as well as medications. This is an example of where we use the measure called the Rappaport that I mentioned earlier. In this measure has higher scores are worse, lower scores are better, indicate more responsiveness. And you can see the number of medications that we tried. And ultimately for this patient here, Ritalin was the medication that was associated with most responsiveness. So we continued that medication in this particular case. It was a different patient than the one I showed earlier. So what are the next steps for disorders of consciousness? If you're interested in this topic, I would encourage you to take a look at the Curing Coma campaign, which you can find here at curingcoma.org. The Curing Coma campaign just had its third annual World Coma Day, which was 24 hours of programming around the world from scientists and families and patients who experienced disorders of consciousness. Some of the research that is moving forward in this area was recently published on these proceedings of the first Pediatric Coma and Disorders of Consciousness Symposia, sponsored by the Curing Coma campaign, as well as the Pediatric Neurocritical Care Research Group and NINDS. That's also a nice resource. And I wanted to throw this in because I thought it might be interesting to this group. There is a small pilot study going on right now at the University of Leeds, looking at psychedelics and disorders of consciousness to see if there's a link between brain complexity and consciousness, and that if psychedelics would be helpful in improving functioning in individuals with disorders of consciousness. This is a small project that that a postdoctoral fellow won the funding for through a video competition, which if you go to this link, you can find more out about that project. So I wanted to thank my collaborators here at the Brain Injury Clinical Research Center and the many trainees and faculty and research assistants who have helped me with all of this work. Thank you very much.
Thank you, Beth. Well done. Nice talk. I'll make sure I understand the kind of the clinical implications of this. Obviously, you've spent a lot of time trying to nail down these issues of how to measure the different components of disordered consciousness. And I think I understood that the most important clinical application of that is the prognostic one, which no doubt is a incredibly huge issue for people. I can just imagine parents hoping desperately that their kids are going to recover. And I gather there's some prognostic value in what category a person is in. So I guess that's the first part of the question. The second part of the question is are there therapeutic implications of where people fall in terms of the categories of measurement and categorization?
Yes, I feel like there are, and was that kind of slide that I showed with kind of assessment informing intervention and intervention informing assessment, that if we know what somebody is, what is likely a response, that's something that we can shape up and continue to work on. So often I might see somebody and their parents are saying that they might be opening their hand on command, but I'm not seeing it, but they're seeing it. That's often because families see things before we do. They're with these children 24/7 and they're watching closely, and the kids are also more likely to demonstrate the responses with families. Well, that is a sign of a minimally conscious state. And if we can then work on that and see what are the barriers that the child doesn't have the attention to do that task. Is it they can't move their hand? Is it both of those things? So if we could work on that and develop a couple of different movements that they can do more consistently, then we have a better window into their underlying cognitive functioning. And sometimes if we have kind of two different responses that are clear enough, we can do even a more thorough evaluation of their cognitive functioning, and they may be doing many more things than we think they're able to. So a good example is we had a different patient with a spinal cord injury, but also in a disorder of consciousness, but was able to, over time, have two clear responses: look up for yes, I think, and look down for no, that were very clearly identifiable. We were able to do a cognitive assessment using the PPVT, a measure of just general vocabulary, intellectual ability, and the patient fell in the low average range. So even though the patient was thought to be, up until very recently, very cognitively impaired, they were much more aware than they were than they were able to initially demonstrate, which kind of changes what their school program is going to be like and how people interact with them when they go home.
Thanks. Rajneesh Mahajan says, are there any residual cognitive deficits in those who have gone through the different stages and have emerged back to consciousness? Are there any longitudinal studies that have looked at this?
Yeah, that's a great question. And there are, but it varies. And kind of, one of my pet peeves is we can only do neuropsychological testing on people who are able to complete neuropsychological testing. And often these patients, if they're very motor impaired, they may be excluded from studies. But certainly any individual that's in a disorder of consciousness for a period of time is going to be at risk for cognitive deficits. But I don't think we fully captured the extent of it, because there are a number of these patients who can't even be tested, even after they're conscious and interactive, using standardized measures.
Right. Interesting. Thanks. Joe Bienvenu says, tough area in children and adults, important work. I may have missed this, but what is storming mentioned in?
Oh, yeah. So that's a physiologic response to severe brain injury where somebody's autonomic system is not regulated well. So they might get high heart rate suddenly or start sweating. It really impacts the ability to care for these children, and it's very distressing for the families. And so it's often something that needs to be treated pharmacologically early on in treatment, which can also then have sedating effects on the patient.
Thanks. Peter Rabins asks, are there data that indicate when rehab should be stopped?
Yeah, that's a great question. And one of the things Joe Finn talks about in that book that I showed early on was that, if you need hip replacement surgery, you go to rehab and you get 8 weeks of rehab or 4 weeks of rehab or whatever it is that's kind of planned for that kind of surgery. Recovery from brain injury is not like recovery from orthopedic injury. And it's really tricky to figure out how long somebody should continue in rehab. And it varies based on where you are in the country and what insurances will pay. Many will not pay for individuals with a disorder of consciousness to go to rehab at all. Often they bypass rehab and go to a nursing home center. And that's why there's these new guidelines to try to help promote that, but it's still a significant issue with payers, even starting rehab. And then ending rehab, it's really a challenge. When do you stop? Often what we do is work to plan to get somebody home so that they can continue rehab in their next phase of rehab at home, which might be less intensive, but also includes school. And with the plan that some children return for inpatient rehab for a boost of care, maybe with some medication management or around a particular issue. But there are no clear guidelines about when rehab should end, and it really does vary across the country and across the world, even in how kind of this is managed.
Thanks. Thanks. Ray DePaulo says, Beth, thanks for reminding us about disorders of consciousness in children where we can't use language and or verbal responses as a guide to assessment. Although I understand the important distinction you're making regarding vegetative states, I suppose translating this back to adults, we'd be talking about the spectrum of coma, stupor, and delirium to fully conscious ?
Yeah, so those terms have really changed and evolved. And so we think now of coma as really defined as that period from injury or illness when there's no eye opening, and vegetative state or unresponsive wakefulness is that now thought to be kind of that period where there is responses are only reflexive in nature and there's not thought to be any cortical processing. So I think there's been more of a movement towards these other kind of ways of describing these states.
Great, thanks. And then Ray asks, are antipsychotics particularly toxic in childhood disorder of consciousness cases?
There's a thought that it certainly could slow down recovery, and especially thinking about as somebody's kind of emerging from a minimally conscious state into more of a delirium or a confusional state, that if we can stay away from those kind of medications and use behavioral environmental modifications to keep somebody safe, that would be a better approach to continue to promote ongoing recovery.
Great. And let me ask you about the sort of clinical context here, because I'm not entirely sure I know the answer, and maybe a lot of people on the call aren't familiar with what you all have at KKI. So there's an inpatient pediatric rehab unit, I take it, or brain injury rehab unit. Is that right?
That's right. And we get referrals from the Johns Hopkins PICU as well as other PICUs around the region and the country. And we tend to see kids after they're medically stable, then they come to us for rehab. In Maryland, because we don't have any long-term care facilities for children, almost all children in a disorder of consciousness would make it to rehab. But I was last week at Nationwide Children's Hospital, for example, and they have a very small rehab hospital, and children with anoxic brain injury, because of their poor prognosis, rarely make it to rehab at all.
How many beds do you have?
We have, it's kind of flexible beds. We budget for about 6 at a time, but sometimes have more brain injury beds.
And do you tend to have a long waiting list to get into it?
It varies, and we try not to, because when these kids are ready for rehab, they're ready for rehab. But COVID made it really hard because of infection control and making sure that people had individual rooms as needed. We also are unusual because we see children with trachs and vents in our rehab setting. Not all rehab hospitals have that capability, especially to see patients on ventilators.
So for the most part, if kids want to get in, you for the most part you can accommodate them. It's not like the neurobehavioral unit where there's many months long wait list.
Yes, there's not that, but we can't always I mean, sometimes we have to redirect them to another rehab facility. We do our best to try to accommodate people as we can.
That's great. That's great. Well, thank you. That was fascinating. And it sounds like you've been doing superb work. Appreciate the talk, and thanks to everybody for joining in.
Thank you.
Hope everybody has a great week. Take care.